Thanks very much. And I think probably most importantly, I'm one of the guinea pigs that are here, I guess, just beginning to understand what PET can actually do potentially for some of our patients and also some of our research. So thank you very much also for the inspiring talk to start with. I hope I can fulfil that role. So thank you very much, and thanks very much to Northern Sydney and Sydney Uni to really getting this right. I think we've tried this before on simple things as simple as kind of an animal echo machine, and we've struggled. So now that we've nailed it with this, hopefully we can form these kind of partnerships going forward. I have to do this. Okay, good. So as cardiologists, we've really made the biggest inroads by actually this kind of probability approaches to population health. I think when the studies such as the Framingham have identified these major risk factors, we've obviously then at a population level made some big progress. And that's partly because, unlike in cancer, we've been really far behind in terms of non-invasive imaging of the actual disease itself, the actual atherosclerosis. And one of my patients nailed it the other day when they said, you know, this is really about a lump in my coronary artery. And I think what we're seeing with imaging these days is actually the opportunity to treat people's atherosclerosis like that. And so moving from a probability situation where we're trying to actually guess who's going to have the catastrophic endpoint of the disease, which is the heart attack, we actually need to move towards that early detection of disease. And another element where things like PET can really help us is the fact that even if we can see the plaque, we actually need to start thinking about plaque not just in the one bucket. There's many different types of phenotypes from an imaging perspective and also from a biological perspective that that imaging can help inform us about. And so, you know, in the setting of colon cancer, we obviously know about how we use in a serial fashion a kind of screening approach to then lead to a more definitive imaging and biopsy approach to then hopefully identify the disease at an early point to treat it far beyond the catastrophic endpoint. And a myocardial infarction is just like an exploding metastasis in someone's head. It is actually obviously a fatal event that shouldn't happen. It is completely preventable. So my program of work is now, really brought together a lot of different partners, and I'm going to focus predominantly on coronary disease today because I think it's a great opportunity with the partnership here. We shouldn't forget, obviously, about the opportunities to image the myocardium, both in terms of masses, infiltration, and also perfusion. But I think the coronary disease side of things is something that we can really use at both a clinical and a research perspective. And so obviously Shane Warne might have had a few traditional risk factors that we knew about, but the two individuals on my left are individuals who suffered acute coronary syndromes and had classic atherosclerosis in their coronary arteries, despite no traditional risk factors and no warning. Equally interesting to someone with a slightly research mind is why individuals like this might actually have no disease, having lived, many, many decades treating their coronary arteries very badly, but actually when you go for some reason to look at them, they don't actually have any plaque. An underappreciated fact is actually what we can learn from our chimpanzee colleagues about humans. Our closest relative, despite having a very nice diet and usually not smoking, actually have they have a much higher LDL cholesterol than most humans, and in fact over 50% higher than the upper threshold for what we treat. And yet they don't get coronary artery disease. So it is something about humans and their susceptibility to this that means that it's far more than the cholesterol that's actually really important here. And I think we need to acknowledge that. So this is all coming towards this important point of shifting a paradigm to this early detection of disease and to a more personalised approach to actually, treating the patient, actually demonstrating remission. And it's a bit like tuberculosis. You're never going to get rid of the granulomas, but you can actually achieve remission, and you'll see that kind of calcification as things stabilise up. And that's what happens with plaque. And so we've actually been driving a really exciting international program of research. CAD Frontiers is actually a not-for-profit that's actually been set up with Northern Sydney and University of Sydney as key initial stakeholders, but also NIF actually as a key partner in this as well. So I think the NCRIS organisations, full stop, have been absolutely fantastic in this, including Andrew Gilbert from Bioplatforms Australia, who's been very generous. And so this is one of the early outputs from this, which is a clinical pathway for how do we actually treat patients that have developed plaque in this way, and how do we actually kind of improve our ability to actually monitor the process, the effectiveness of that treatment. And so we'd like to see heart attack is something that is completely preventable. Sorry, that's my 11-year-old child ringing on the watch. I'll answer him in a second. Hopefully, oh, there we go. So coronary disease is actually obviously very common, and we kind of have made incremental approaches, but the time is right to actually make a big difference and to actually begin to target that. So here are some of the individuals, including, I think Wojcik might be here in the room. And this, if you follow the QR code, will link you to some of our ambitious goals. We were successful in stage 1 of the Frontiers program a couple of years ago, and were lucky at the time to receive the initial investment of $1 million to bring all those partners together. We were not successful in inverted commas in stage 2, but we actually have continued many of those partnerships, in fact, almost all of them, towards our goals of early diagnostic testing, implementing those diagnostic tests, and then ultimately treating them with new drugs. Here are just some of the industry partners, including our NIF colleagues. And one of the exciting resources is actually the BioHeart resource. And this might please some of Simon's earlier comments, in the sense that as a clinician, we're actually very much into systems biology. And in order to kind of follow our oncology colleagues, we need to actually be able to have some markers in the blood that then kind of enriches our pretest probability in order to actually image those individuals. And I think that can be with a variety of tools. We have a very close relationship with radiology here, and actually an excellent service in the CT coronary side of things. And actually bringing that together on the new instrument is actually going to be fantastic. Martin, do you mind answering him? I'll call him back in a sec, sorry. He's just finishing school camp, I think. Martin knows Henry very well. So what we're keen on doing here is actually, we collect blood at the time of the CTCA, and obviously if we can actually combine that with additional information that's available through PET, we have a very strong relationship with multiple omics experts and also bioinformaticians, and have over 1 million different data points per patient. And we've already come up with a number of signatures, particularly in the immune side of things, that actually are quite prognostic for the presence of plaque. And if you look in this room and think about all of those that might be actually having silent coronary disease, that if you knew about, simple treatments, including really driving that LDL below 1.4, can achieve that remission of plaque. And so this is the concept so far, but also, like cancer, being able to recruit patients who've got non-calcified plaque that might be characterised in different ways, but also with particular molecular phenotypes, we can actually then do dedicated trials of new drug therapies. I'm going to flick through this, but the important finding is that in many of the big biobank studies, such as the UK Biobank, we've been able to look at healthy individuals, but the assumption that they don't have coronary disease is actually really a problem when you're actually trying to do discovery work for novel biomarkers. And so, particularly with the individuals like I showed earlier, the resilient patients who actually have no coronary disease are really fascinating from both a diagnostic and a therapeutic target perspective, what we can learn from those individuals. And so imaging tells us a lot, particularly in an asymptomatic population. And it's not just the stenosis that we're looking at. This is an example of some of the inflammatory pattern that we can actually measure just using standard CT in the pericoronary adipose tissue. But imagine what we can do if we can improve our ability with PET. And so opportunities with PET plaque imaging is obviously identifying unstable plaque that might be the cause of an event or the likely future event. And I think also enhancing the clustering of plaque phenotyping for better discovery of individual types of signalling enrichment. I think the challenges around cardiac motion and partial volume effects can limit spatial resolution and some of the quantitative accuracy in regard to coronary disease, but we're seeing progress with that. And I think some of the early application has obviously been to carotids and aorta, but I think the total body PET allows us to think about doing this much better for coronaries. So ideal PET traces for atherosclerosis, I think ultimately one that obviously has biological correlation and associates with risk, one that's actually easy to make, inexpensive and with a long half-life. And here's some of the markers that we've actually obviously seen translate, particularly in terms of that carotid and aortic side of things. So FDG, we've got the sodium fluoride, and then we've got the dotatate. But I think also in terms of specific molecular targeting, we have seen some targeting, particularly for activated platelets. The glycoprotein 2B3A receptor on activated platelets has actually been associated with the thrombus formation on ruptured plaque in human coronaries as well as in preclinical models. So I guess that's just some examples there, particularly demonstrating the 18F signal there at baseline and also after treatment, demonstrating that as the actual inflammatory component comes, it can settle down. So the limitations are obvious to most of this audience, and I think hopefully going to be overcome. I think just moving on to the concept of how we can actually use this facility for partnering with drug development side of things, I think this is a really exciting space. If we can actually measure, the better we can measure that plaque activity, the better we can actually test new drugs that are actually acting beyond traditional risk factors. And so in this case, we've actually been leading a work with an international consortium. The FDA have actually said to us, you guys have got to catch up with the rest of the world here. 45% of the drugs we approve are based on surrogates. And now that we can actually measure plaque and plaque activity, we're actually working very closely with them, with both academic and industry partners to try to come up with CT measures of plaque as valid surrogate endpoints for new drugs. And I think that's a great opportunity for this site here. I will just skip on to a really terrific opportunity, which is the Colcardia study. This is an NH&MRC clinical trial that has been awarded funding from Sanjay and also Tony Keach. And it's really attracted an opportunity to do the imaging sub-study of around 200 patients with serial PET, where it's actually the primary endpoint's carotids, but we'll also be able to look at coronaries. And so this is something that we're really excited about taking through to the instrument. So I am finishing because I have a very nice sign here telling me to finish, and hopefully Martin solved my 11-year-old's problem. We're far from winning with coronary disease, but I think both from a diagnostic and a therapeutic perspective, imaging is at the centre of this, and hopefully I've excited you about what that might mean. Ultimately, I think we are very well placed here at North Shore and the university to try to bring that translational piece to benefit our patients. So thank you very much.